Good evening, everyone. My name is Francois du Plessis. I'm one of the emergency medicine registrars currently at the University of the Witwatersrand. And tonight I'm just going to be giving a presentation on intubation of the critically unwell child. So first thing when talking about this is I'd like to go over the anatomical variants and differences that we find in children as opposed to adults, because it does guide our technique and planning that we do for these children as well, that we often see in the ED. With this talk in mind, I'd also just like everyone to remember that we're talking about critically unwell patients here. So patients who are unstable, patients who have been involved in massive trauma, any burns patients as well with large burn areas. But these are not your elective type intubations, but these are true emergency intubations in patients who are very sick. Um, so just some of the anatomical variants to go over. So we have a picture on the right. You can physically see just the change in shapes itself, but important things for us to remember is that firstly that the newborns themselves are obligate nose breathers. They're very narrow nostrils as well. You've got limited space to work with. The occiput is very rounded, often resulting in flexion at the neck of these patients, making sometimes our view a bit difficult. The tongue is relatively large for the mouth. The epiglottis, it's going to be omega shaped. It's quite floppy. It's a lot larger as well. The larynx sits a lot higher in the neck, which also makes our view of this space a bit more difficult. And the vocal cords also slant a bit anteriorly. They're not parallel or perpendicular, rather, as you would see in an adult. They're very short necks. And just remember that the cricoid ring is part of the narrowest diameter. And all of this speaks to the fact that the intubation of a child, in and of itself, is already a difficult airway, regardless of the fact that in these patients that we're going to be talking about, on top of this, they're going to be critically ill in some regard. So there's many different reasons as to why the pediatric airway can be difficult, let alone the anatomy. But some other physical features that might be predicting a difficult airway is we have poor mouth opening in children. They might have long or overriding incisors. The mandible might be protruding. The palate itself is also quite arched, it can be narrow, short and wide necks, and limited head and neck mobility. This all speaks to the usual maneuvers that we would use might not be as effective in children as they would be as we see in adults. Some scenarios that predict difficult airways. So any children under the age of 1 year is a difficult airway, regardless. And in these children as well, you often see airway swelling, airway bleeding, very friable tissues as well. We all know about laryngotracheal bronchitis and epiglottitis, common airway infections, tonsillitis that might be causing small spaces that may be difficult to intubate these patients, and then also just positioning difficulties in general. Essentially, it boils down to the fact that children have narrow airways. They have a larger tongue that takes up more space. They have a shorter trachea, meaning manipulations are more difficult. Larger occiput, so patient positioning is difficult. A high anterior larynx that is difficult to bring into view. And on top of this, they also have a reduced functional residual capacity and increased metabolic needs. Which as a baseline means that these children do not have the time that we can afford them for their apnea before intubating them, and that if they're critically ill as well, this demand on their body is even higher. So this is something that I came across that I thought is very important for us to know and really points out to why time is of the essence. The graph on the right, if you look at it, essentially is looking at the hemoglobin desaturation with an initial alveolar O2 of about 0.87 or 87%. So a patient that you would be pre-oxygenating. On the left, you can see the saturation of oxygen measured in percentage, and on the bottom is the time of ventilation being 0. So essentially the apnea time, and how the graph represents how quickly the saturation will fall in relation to an apnea time. On the far right on the bottom, you can see that there's a mean time to recovery of twitch when you're giving 1 milligram per kilogram of succinylcholine or choline. So essentially, this is the point in time is when you'll be getting back muscle tone and at 90% adequate breaths being taken by the patient. So on average, it's about 6.8 to 10.2 minutes. To note, obviously on the far right, we have a normal 70 kg adult, and we have about 4 to 5 minutes of true apnea time before we start seeing a significant decrease in the saturation. For a moderately ill 70 kg adult, though, you can see that that graph has significantly shifted to the left, and that our time of apnea before we start seeing significant changes is reduced by about 1 to 2 minutes. For a child, that time that it takes to hemoglobin desaturation is even faster, and the drop-off is even more severe. Um, so for them, they only really have about 1 to 2 minutes of apnea time before there's a significant drop. So if you're having 1 to 2 minutes before you're starting to see in a normal child that there's a drop in the hemoglobin desaturation, you can just imagine what it's going to look like in someone who is moderately or even severely ill. You might even have seconds before you start seeing desaturation. Um, and obviously, when intubating these patients, hypoxia is something that we do need to avoid at all costs. It's going to increase any morbidity or mortalities that these children have, and they're very dependent on having effective saturation and oxygenation. So it all boils down to the pneumonia that fail to plan or plan to fail. A lot of and what I'm taking from today is from Don't Forget the Bubbles. It's a fantastic website. It's uses a bunch of the British and Australian guidelines and a lot of emergency pediatrician practitioners as well as ICU teams who get together and essentially have a website that they run. And I really like this way that they break it down. So the first thing they say is you're going to be assessing your patients. So you're going to be doing your ABCDEs. And with this assessing, if you have the time as well, do your lemons and your boots and your moods. Look for and predict any difficulties in your airway so that you can essentially plan for it and make sure that your team is aware of what's going on. Whilst you're doing your assessment of your ABCDEs, it's important to also resuscitate this patient as best as you possibly can before intervening with the intubation. Intubation itself is not a benign process, and you will be worsening the patient's acidosis. You're going to be causing hypoxia, increases in CO2. The drugs that you give are also going to have various forms of cardiac effects, vasoplegic effects potentially as well. So if you resuscitate your patient to the max that you possibly can, it's going to improve your outcomes when you inevitably have to intubate these patients. So IV access is going to be vital. Fluids, it's recommended that you give 10 ml per kg aliquots and you review the response to those aliquots. So don't go to max initially, but start at the 10 ml per kg, give them the 10 ml per kg, and then review. See, is there an improvement in our blood pressure and our heart rate in the patient's GCS potentially? What does their cap refill time look like? Early initiation of inotropes if needs be as well, so that you can with the expected drop in your blood pressure and potential also sympathetic depression some of these drugs are going to cause, that you will mitigate that effect. And then correct any correctables that you can do without wasting time. If hypoglycemia, if you see electrolyte abnormalities or anything like that, if you can treat hypothermia, anything that comes up with your ABCD assessment. Um, Right next door to this, they talk about location. So a lot of it speaks to that the ergonomics of the situation. If you are comfortable and your team is comfortable and the team is well experienced and you're doing this in the right place at the right time, your success rate is going to increase. So it's all about your familiarity of your equipment. Know what space you're working in, where you would do this. You do not want to be looking for things whilst you're doing this procedure. You want to be familiar with where it is and how to get hold of it. Make sure that you have a space that can also deal with the potential for deterioration. To know that with this intubation, with this child that is critically unwell, that you might be faced with a situation where a cardiac arrest does happen, and you need to be prepped for that and able to respond to that also appropriately. With that being said, this is where we come to plan. Always, always, always have an airway checklist and go through that checklist, regardless of what it is that you use. Is it a stop IC bars situation? Do you use the 6 metal, 6 plastics? But also verbalize that checklist to your team that you're working with so that everyone can remind you potentially of things that you've missed and also everyone knows what's going on. With that also being said, it's very important to orientate your team, to let them know plan A is going to be we will give drugs XYZ and we will be attempting an intubation. If plan A fails, then plan B is going to be placement of an LMA per se. And if plan B fails, then we'll move on to plan C. And also to give roles to people regarding those specific plans. Because once again, we want to cognitively offload in these situations, and we want to be able to respond quickly to a situation that is very dynamic and can change very, very quickly as well. Recommended drugs to use, and there's a little visual that I'll show later just about this. It's very easy to remember, but ketamine, rocuronium, and then plus minus fentanyl, just depending on your patient. The procedure itself, just some important things to remember. So it's recommended that an NGT with some aspiration just to decrease that pressure in the stomach itself is actually recommended. And you can be quite liberal with that aspiration itself. It's important to ramp the shoulders just because of this large occiput itself, the short neck. Any flexion of that neck is going to make your viewing of your larynx and your cords incredibly difficult. You can do this either with fluids, blankets. There are specific rubber ramps that are actually created that you can also buy for units. But in some degree, just ramp those shoulders and make sure that that ramping that you're using is also secure, that it doesn't shift during your procedure. And then also to pre-oxygenate these patients as much as you possibly can, whether this be with the bag mask ventilation. Consider high flow nasal cannula as well for these patients if you have it available, and also apneic oxygenation whilst you're intubating with some degree of nasal prongs or high flow. And then also to remember to start your end tidal CO2 monitoring as soon as possible. Not only will it give you information on your success with the intubation itself, but if you do have a situation where there is some form of cardiac arrest, it might be one of your first parameters that you will see and be able to pick that up. And also any problems with bronchospasms or laryngospasms, anything like that. So this little visual here, I find it's incredibly useful. It's essentially a simplified version of what you absolutely have to remember when intubating a child, and the equipment and drugs that you're going to use. And you can stick to this formula as well. So predicted ETT size and length for uncuffed and cuffed, and the predicted length as well in centimeters at the depth that you're going to be placing it for an oral or a nasal tube. Um, to note, there is a note here to say that if a patient with croup, to try and use tubes that are 0.5 to one size smaller, as there is going to be swelling, there is going to be difficulty. Any trauma that you create in that area or failed intubation is going to cause that swelling to close up even more and making the further attempts at intubation even more difficult. So for the doses of ketamine, fentanyl, and rocuronium, as I said, I really like this and just how simple it is. It's not difficult maths. It doesn't require you to remember a lot. And once again, it speaks to that cognitive offloading that we need in these times. So 1 milligram per kilogram of ketamine, 1 microgram per kilogram of fentanyl, and 1 milligram per kilogram of rocuronium. And you'll be forming your RSIs using those drugs. And these are drugs that are preferred. They've shown to have less adverse outcomes in these patients as well. And once again, it's a simple formula to remember and to give the children. So some suggestions as well, when it comes to the drugs, is what you should have available at any critical unwell intubation. Um, so first off, you need adrenaline, and this is going to be your cardiac arrest dose. So to draw up a 1 to 10,000 solution, and to remember that it's zero point 0.1 mils per kg, which works out to 10 mics per kg as per PALS guideline. So once again, speaking to this, that if there is any delay, or you do have a situation where the acidosis worsens, or this patient does have, whatever reason, a prolonged hypoxia because of a difficult intubation, there is a likelihood of arrest, and this needs to be ready and at hand for immediate use. Not to be drawn up in the time of the resus, but to be drawn up so that it can be given as soon as possible. You also need dilute adrenaline. This is for your hypotension and bradycardias. So here you're going to take a zero point 0.1 moles per kg of the 1 to 10,000 solution. So 1 mole of that diluted down to 10 moles. You can use this preemptively, and what they suggest is actually if the heart rate or blood pressure drifts from 20% from your baseline. Speaking to this just with the heart rate and blood pressure as well in your vital signs, it's also incredibly important that to have a team member who's dedicated to working out what your expected vitals and what the normal ranges for the child is. Um, if you have the hands and the team to do that, it's amazing. And then you can have them work out the formulas, work out all your drugs. And then once again, you're not having to think in the middle of any form of resuscitation or during the intubation. If you don't have someone like that, then there's multiple different apps that can be used as well. I personally use Pedistat. I find that it's incredibly useful and it's very well and simply laid out. But I would not recommend that during such a stressful situation that you're trying to do mental maths at the same time. So have someone dedicated to doing this and prepping it beforehand so that you once again just have everything there. You don't have to think. So balanced solutions or blood products. This is speaking to if you have anyone with hypotension. So again, it's recommended, these we spoke about it, these 10 mils per kg aliquots, and then you watch it and see and respond appropriately to how the patient is responding. And once again, the choice of if you're going to use a balanced solution or blood product is going to depend on the pathology. If you have someone who's involved in trauma and you know there's active bleeding, then we would want to use blood products. Obviously, if it's someone who's potentially septic or severe gastroenteritis, then blood products is not going to be our first jump to, but something like a balanced solution. From the Resus Council update in 2021, balanced solutions isn't the primary choice. The 0.9% saline may worsen acidosis, and then also in conjunction with this will worsen your efficacy of your inotropes. And it should also be recommended that you have atropine on hand for any bradycardias. The dose is 600 micrograms per kilogram, and you can use a max of 3 milligrams in these patients. So now moving on to the procedure itself and the intubation. So we've assessed, we've resuscitated as best as we can, we've orientated our teams, we've made a plan, we have everything prepped, we're in the best situation that we can hope for, but the intubation itself is going to be difficult. And some of the situations that you might find yourself in is one that you cannot see. You cannot see the vocal cords, you cannot see where you're intubating. I don't know how to get that tube in. Um, Second scenario can be a drowned airway. So an airway that's incredibly soiled, there's gastric aspirate, it's potentially blood that's just filling up that entire space, and you physically cannot see where you're going. And then one of the final situations is a can't intubate scenario. And when you get to a can't intubate scenario, it's important to recognize this is now a situation where I'm still able to ventilate this patient, which in that case you can use our Vortex approach and other mechanisms to ventilate that patient. And then while you're formalizing some plan to get a formal tube in or a definitive airway in, or is it a true SEO event, which is a I can't intubate and I cannot oxygenate this patient either, which is going to lead us to talking about front of neck access in children. So if you're stuck in a situation where you cannot see, once again, it's important to remember as well that doing the same thing over and over will yield the same results. If you do not make a change, if you do not make some form of an adjustment, nothing will change. You will not be able to see. So the adjustments that we can make, so one is to technique. Another one is to patient position. Do I need to ramp the bed? Do I need to ramp their shoulders more? Am I in a comfortable position with them? Are they at the correct height? Um, are they tilted to the side? Is there anything that I can do to reposition them? Third thing, also talking about the doctor performing the intubation. Once again, in situations like this, it should be the most experienced practitioner who's performing this intubation or someone who's well versed in intubations and the use of the various equipment that we have. Obviously, if you are also in a situation where you're using a double setup, that might be a bit difficult because it might be the most senior person who's actually going to be setting up for your surgical airway. But it should be the best person to do this. We're not going to be having the student intubating a patient in this scenario because it needs to happen on that first pass success is what we're aiming for here. And there really is very little margin for error. And then the last thing to also look at is equipment. Is my laryngoscope the correct size? Is it the correct shape? Am I using a straight blade? Am I using a curved blade? Is it working? Am I using a bougie? Am I using an introducer? Do I know how to use a bougie? Do I know how to use an introducer? I'm not going to go into the nitty-gritties of each of these because I think each of those on their own is a whole topic, and will be here for a very long time. But it's, I want to have this idea that these are things that should be triggering in your mind if you're ever in these situations. It's a very high stress time and it's very easy to feel that stress and panic and to forget these things. But if we just have some idea of what we should be looking for, it's small adjustments we can make to help us perform these intubations to the best of our ability. Um, to note, just these are something that I wanted to mention. We teach it in AIM a lot as well, but it's often forgotten, and it's three simple things that we can do. We usually got the three things to do with two hands, and this speaks to technique when you're intubating. I included the gentle here because remember, these are children. Their tissue is very soft and friable. I'll speak about it a bit later with the front of neck axis as well, but remember the cartilage is also not entirely formed. It's very easy to cause fractures, to cause gum damage. So the first one is going to be to bend at the head. So what you'll be doing is it's always two hands. So one hand laryngoscope, one hand behind the child's head, and you're going to be raising that head and extending their neck and hopefully getting a better line of sight towards the cords. External laryngeal manipulation. So important. So one hand again on the laryngoscope, and your other hand is going to be gently manipulating the larynx itself to see to hopefully get a better view. Once you have the best view that you can obtain, you're going to ask someone else to put their hand there and hold it in place. Don't ask someone else to move the larynx for you because they cannot see what you can see. So their left and their right and their up and down is going to look in their minds a lot different to what you can physically see. And you're just going to be delaying essentially the effectiveness of this. And then the other thing that you can do is a two-handed pull where when we're intubating these patients, there's no hinging at the wrist. but a thumb is on the back of the handle and we're pointing and pushing away, so away from us, that all that soft tissue can move. So you can ask someone to grab the handle with another hand and they just apply a little bit of pressure and a little bit of pull in that space to hopefully move those soft tissues and pull that larynx into view. But very simple things, very quick things to do, and it's important that we remember to do these as well. So now I'm going to be moving on to the drowned airway. Um, so a drowned airway, speaking to an airway where when you go in to intubate, all you can see essentially is fluid. There could be blood, it could be excessive secretions, it could be gastric aspirates, it could be a whole host of different things. But the physical thing is that you cannot see anything beyond that fluid itself. So once again, as with anything, call for help and communicate. It's very important in these cases that that is one of the things that is always happening. Always communicate with your team what's happening and always call for help. So the drowned airway algorithm they speak about is, so the first thing is that you're going to attempt airway suction. So we're going to use the salad park technique. As long as our saturation is obviously more than 88% in this regards. Because once again, if we go back to that graph right in the beginning, once we've reached a saturation of 88% or even lower, once we hit 90 and going down, there's going to be a very steep drop off. And with that drop off itself, you're going to have significant hypoxia. It's going to interfere with your oxygen delivery in the body in someone who already has potentially a low HB, a compromised cardiac output as well, has a vasoplegic type shock, and again, wants some degree of cardiac outputs problems. So if you do desaturate, you're going to not delay and you're going to be moving to essentially a front of neck axis. But you can use the salad park technique. And the way that this is described is that you will be introducing a suction catheter with your laryngoscope blade and essentially suctioning as you're going in with the laryngoscope, and then hopefully that will allow you to see where the cords are and you can pass your tube. You hold it in the same hand as your laryngoscope, or you ask someone else to bring it in from the left-hand side. Don't bring it in from the same side as your tube because once again, space is limited, especially in children. So it's important that if they're coming in from the left-hand side with your laryngoscope, that that space is dedicated to the suctioning, and then you have all the space on the right to maneuver and manipulate your bougie or tube as needs be. If this isn't working, but your saturation is still maintaining, then you can attempt a Seldinger intubation with large bore suction. So for this step, it's important that firstly, this needs to have been prepped beforehand. I'll show a picture of it, and it's something that needs to be essentially jimmied a little bit. And it's also importantly, it needs to be large bore suction. This isn't going to work with small gastric type suction tubings or anything that doesn't essentially have a large open tip. But what's going to happen here is that you will have an introducer, but usually a bougie in this case, physically strapped to your large bore suction, and you'll be passing that into the in between the cords, and then you'll be feeding your bougie down and then pulling your suction out, and then you can pass your tube over. So once again, if it's not prepped beforehand, it's not something that you're going to take the time to make in the situation. So usually if you see here, if they even say if large bore suction isn't immediately available, you just skip the step. The third thing that we can do for drowned airways as well, is that we can attempt what we call esophageal diversion. So what happens here is that you're going to have two different ET tubes, same size, maybe one bigger, one smaller, but you have one dedicated for the for your trachea, and one essentially is going to go into the esophagus. Idea here is that you will still be using your laryngoscope to some extent to get the tongue out of the way, and you'll be blindly intubating with your endotracheal tube. And one of two things is going to happen. Either that tube, by some miracle, is going to pass through the vocal cords and you've tubed the patient. If that doesn't happen, it's very likely going to go down the esophagus. So you leave it in the esophagus, you inflate the bulb, and then you go in again and you now look for the cords. And hopefully that ET tube going into the esophagus is going to cause some diversion of tissues, is hopefully going to also prevent, if it is gastric aspirate in this regards, hopefully some diminished level of that as well, and hopefully give you a better view. Obviously, suction is going to be used continuously in all of these cases. If this doesn't work, or if you have the significant desaturation, then we're going to be moving into front of neck abscess itself, or which we'll be talking about next. So here's just a few photos just of what I was speaking about. So you can see on the left, they've got the stylets and suction tubing and silk tape, and how they MacGyvered the large bore suction device onto onto the stylet itself, and that's what you're going to be using to intubate. That's that second type. That's like the Soldingen technique is what they just speak about. But once again, it needs to be prepped beforehand, and it's not something that a lot of units will have prepped in that regard. And again, it's not something you can necessarily keep in your research trolley forever. You're using silk tape. It's tubing that can also crack. You need the stylets for other things as well. On the right, what's important here is that it's they use what they call a Ducanter the HID suction catheters. But if you look at the tips themselves are massive, large, and open. Reason for that is that if you have blood, it's very difficult to suction up if you don't have a large bore catheter. It's going to cause clots. More often than not, it won't actually suction through something with a smaller hole. And if you have gastric aspirates or something as well, there's going to potentially be bits of food, and you have large volumes as well of this fluid. That's why it's a drowned airway. So you need a large bore catheter to physically suction everything out. And this is just an image just speaking to that esophageal diversion. So you can see that there's one endotracheal tube that's gone down into the esophagus. It's been inflated. It's hopefully creating some diversion, some sort of blockage, and then they're performing a normal intubation with another ETT. So the last thing that we're going to be speaking about is what happens if you do have a SEO event. So this is I can't intubate, but I also cannot oxygenate this patient. Um, in an ideal setting where you have people on hand, you have a hospital that has everyone, all the specialties on site as well. Ideally, you'd need ENT here for help, mainly because as you note on the last point there, is that children from the ages of 1 to 8 years should have a formal tracheostomy done if an ENT surgeon is present, because front of neck access in children is incredibly difficult and has quite significant complications as well. And a lot of trauma can be caused also to the larynx and the soft cartilage as well. Um, so you're going to call ENT for help. I know in our setting sometimes that isn't always available and they might not be on site, but if they are, then you can ask for them. With that being said as well, call the most senior person available, call your consultant, let someone know what's happening. You can call various other departments as well if you need hands. There's anesthetics, there's ICU, pediatrics. But once again, if you are dealing with the airway, then continue with the airway management, but get as many hands as you can for this. You're going to continue your airway management. That doesn't stop. And with that saying being said as well, you do not stop any attempts to oxygenate as well. That needs to continue regardless of what's happening. And here we're going to use the Vortex approach, which we'll look at the next slide. But we're going to be using these lifelines that we're hopefully going to be using to oxygenate this patient and continue the airway management as best as possible whilst a SEO event is being declared. With that being said, it needs to be verbalized loudly, and the entire team needs to be aware that this is happening. Because now we are moving into a situation where you're going to have a second team who's going to be doing a front of neck access. So there are a lot of moving parts, and you need to be able to communicate effectively with each other. This needs to happen quickly. Right? If you have a patient that's critically ill and you're suspecting a difficult airway, you should have a double setup regardless. Because once again, critically ill patients cannot tolerate prolonged hypoxia. It will result in a cardiac arrest. And regardless of what their precipitating pathology is, any form of cardiac arrest is going to increase their morbidity or mortalities long term, have long term effects, have immediate effects in our immediate management in ICU, and it's what we're trying to avoid. So if you plan to fail, or you fail to plan, you're going to plan to fail. So you should have a two team setup for these things in any case, and someone who's going to be dedicated front of neck access. One of the hardest things about these SEO events, and if you read through the literature and just people's talks about it, is the decision to do it. Um, the procedure themselves, obviously, when you're speaking about children, is difficult in and of itself, but it's very difficult to make that decision because it's a very quick decision that needs to be made, and it has long-lasting effects as well. But there's a lot of mental block that's been described with making these events. So if you are in a situation like this and you cannot intubate, you cannot oxygenate, you've got your three strikes and you're out, or you've tried your twice on intubations with the best attempts that you can to visualize, you're using a VL, you've done your bend at the head, you've done your ELM, everything. Do not delay this because you will end up in a situation where the patient's going to arrest. So this is the vortex. So essentially, what it speaks to is that in the outermost ring, in the green ring, is when you're in your safe zone itself. Then as you're heading in, We have three separate lifelines. So we have bag mask ventilation, we have LMAs, and we have endotracheal tubes. And with the Vortex, you're going to, when you're in this point where you're now trying to salvage this airway, you're going to be circling around in a spiral, going from one to the next to the other to the other one to the next to the other to try and get it. You get maximum 3 attempts at any lifeline, unless one of them obviously is some degree of a game changer. So we somehow managed to bag mask ventilate the patient. That's okay. Then we're going to bag mask ventilate them as best as we possibly can and get them to a point where they're more stable or their oxygen saturation is a bit better. And then we can move on and we can make more plans from there. When you're moving from each lifeline to the next, if it's not working, what you need to consider is everything we've spoken about. So you need to consider position, manipulations. Is it a problem with the head and neck? Is it a problem with my larynx itself? Can I use some ELM? Or is it a device issue? Is my mask the right size? Is my ETT the right size? Is my LMA the right size as well? Any other forms of adjuncts that you can also use? Bougies. Is there anything? Am I using the right blades? Everything size, type. Am I using suction? What is my oxygen flow? And then also looking at muscle tone. With this being said with the Vortex as well, it's important that they do mention that at least one of these attempts should be the most experienced clinician. And it's once again, it's not 3 attempts per person. It's maximum 3 attempts. So 1, 2, 3, and it's done. It's not 1, 2, 3. I try 1, 2, 3. Person B tries. Then we've missed the point essentially. And with each move from each section of the Vortex to the next, it needs to be once again communicated and again the situation escalated to the team as well to say, this has failed. We are now moving on to this attempt, and the status of this patient, this airway, is becoming more and more dangerous and more difficult, so that everyone's aware of what's going on. If this isn't working, and we have a true can't intubate, can't oxygenate, and you've called for front of neck access, now the question is, how do we do this? There's multiple different techniques, and I'm just going to be speaking to what techniques there are to use and who to use them in, than as to the specific techniques themselves. There's multiple videos out there. Some of them are very, very fine motor skill events. A lot of the equipment we might not necessarily have as well. And if you aren't familiar with this equipment as well, it's not suggested that you do the procedure. You don't want to be doing a front of neck access, and it's the first time that you've ever seen what a Seldinger technique pack looks like. So what you've been taught, what you've been used to, then use that. But if you aren't familiar with the technique, rather don't use it because of the risks of causing injury and various forms of complications. So looking through some of the things, this is from various papers I've looked through, various websites, various FOAMEDs. There's actually very little evidence and guidelines for children under 1 year of age. I cannot give you a straightforward answer as to what is going to be your ideal situation in front of neck abscess in these cases. I would think that percutaneous techniques are going to be favorable in this just because of the size. But once again, I unfortunately I found very little evidence on that. Hopefully, we can have a discussion afterwards if anyone knows anything more. For 1 to 8 year old children, it's recommended that you use percutaneous techniques and formal tracheotomies. So the formal tracheotomy is something that's going to be done by the ENT, not by us in the emergency department, but it's percutaneous techniques. You do not have the space to create a surgical incision. You're going to be using needles and threading wires to be able to get into that space. And then for anyone over 8 years of age, you can then move on to surgical procedures, but you can still use your percutaneous as well. So these are some of the pediatric phono techniques, as well as the potential complications. So for percutaneous, so this is for our children from 1 to 8 years old, you're going to be using wire-guided cricothyroidotomies or the Seldinger techniques. You can use a catheter tip over a needle. So you insert a needle into the space and then you put a catheter over. And once again, we're aiming for that space between your thyroid cartilages and your cric. And just important that when you are feeling and marking this off as well in these children, it's very delicate structures. Simple enough pressure and you can cause fractures, which can cause hematomas, bleeding into that space. So just be very, very gentle when you're doing this. And then you can also get transtracheal cannulation as well. Once again, potential complications, so bleeding is a big one. Tracheal wall injury itself, if you go too far, you puncture the rear end of the trachea. If you go even too deep, you could cause esophageal injuries. Anything like this is going to make your ventilation difficult, increases your risk of infection, mediastinitis, anything like that. And then also pre or retrotracheal positioning of that catheter over needle. So you go into the back and then you thread everything through, and now you've created a false track behind the trachea. That's what you're ventilating. And then transtracheal cannulations is your risk of pneumothorax, emphysema, and cannula misplacement as well. A lot of this you're also going to need to use jet ventilation for these patients. Because it is a very, very fine thing. And once again, you either need to have the specific set available to you that you can actually set your pressures to, or what you can do is you can take a piece of suction tubing and you cut essentially a small hole in the top, almost like on a flute or a recorder type thing, and you can use that to breathe. So 1, 2, 3, open, 1, 2, 3, open it. Very similar to a neopuff, and then you set your flow at the wall to decide that. Or there's another way which you can use a 2 ml syringe, but I'm not going to be speaking about that. I think if you have time in your units, maybe speak to the registrars or the consultants about these things. They're very finicky procedures. Um, for the surgical techniques, so once again, we see we've got the tracheotomies, but this was not going to be being done by us. And again, bleeding and injuries of adjacent structures. But a cricothyroidotomy with scalpel and bougie is what's recommended. So scalpel, finger, bougie. You're going to make your incision over the space. You're going to incise that membrane. You're going to be putting your finger in, feeding a bougie, and then railroading whatever size you can fit. And the size are also obviously dependent on the age of the patient, which I haven't included here. Once again, bleeding, risk of tracheal injury, as well as stenosis. And once again, I'm going to just go back to the anatomy. That cricoid ring is actually the narrowest part of the airway. So the space that you would usually consider having in an adult patient, for example, is a lot less. And the space that you see if you're going from the top as well, is multitudes bigger than what is actually happening at that tracheal ring. So it's very important to recognize that risk to damage of adjacent structures is quite high, as well as retrotracheal positioning of anything as well. These are my references. Um, I think a lot of what I wanted to get across in this presentation is that you have to plan for these situations. And with that being said, do not rush. We want to be fast, we want to be quick, we want to be effective, but we do not want to rush. I do not just want to have a patient come in and immediately I see that their GCS is 2, I don't do a proper assessment, and I try to throw Airway in, and what ends up happening is that patient crashes on me. Because the pH was 6.7 before we started, we had the time to set up an adequate IV line. So plan as best as you can, communicate with your team, expect the worst and plan for it as well. These patients are not just anatomically difficult airways, but what we call physiological difficult airways, as we've mentioned. They are going to be acidotic. They are going to have compromised cardiac outputs, and everything that you are giving is going to be potentially worsening that situation. But you cannot deny giving them that or attempting the intubation for the fear and risk of the side effects of those medications. So it has to be done. So plan, 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 have an approach, and communicate.